And now I'd like to introduce Dr. Thompson. Dr. Thompson serves on Wolf's Advisory Council and is an obstetrician gynecologist physician currently in practice in the USA. She has provided medical care to women and girls for over 17 years in both the USA and other countries, including Vietnam, Haiti, and China. She has extensive experience with caring for victims of male violence, rape, incarceration, and human trafficking. She has spent her entire professional career caring for women and girls and will always advocate for their rights, physical safety, and privacy. Thank you so much for joining us, Dr. Thompson, and take it away.
All right. Well, thank you so much, Amanda, and thank you, Patrice, and thank you everybody for attending the webinar this evening. I hope that it's an informative talk, and hope that at the end we can have maybe a little bit of discussion if there's time. So I just want to thank you all for inviting me to speak tonight. So the topic that I'm going to talk about is a little bit different than the title that was introduced in the invitation. So I am going to talk about reproductive freedom and women's access and women-centered care, but I changed the title a little bit to calling it reproductive freedom in our current era, 2022, and I'm titling it A Brave New World. So what I'd like to talk about is the dichotomy between actualizing reproductive justice within the reality of reproductive coercion. And I don't know if there's anyone here in the attendance who is a social scientist or has heard of reproductive coercion, but I'd like to talk about that a little bit as it pertains to reproductive justice. And I'll kind of go into what I'm talking about in terms of what this means for accessing reproductive freedom in today's world. So again, thank you all for coming. Just a couple of disclosures. I have no financial disclosures or anything like that to disclose. Again, please feel free to type questions in for the end, and all views are my own. So the goals of this discussion tonight are really just a few, and I'll go over these right now. So first of all, what do I mean when I talk about reproductive coercion? So we're going to talk about what that actually is. And then we're going to talk about how the medical relationship and the professional sphere kind of promotes one tenet of reproductive justice, and it also has the risk of actually causing and contributing to reproductive coercion at the same time. And I'll get into that a little later in the talk too. But first of all, I'd like to talk about what reproductive coercion actually is. Okay. So reproductive coercion and abuse is a specific form of violence against women and girls, which is hidden. It's perpetrated against women, usually by a male intimate partner, but it can be used against women by other family members as well. At its core, it's an interpersonal dynamic. It's not structural or societal. And this was first described by a researcher by the name of Dr. Elizabeth Miller in 2010. And she did some research at that time, which was pretty groundbreaking, and I'll get to that in a second. So what made her look into this topic? Well, at the time that she was doing her research, there were more and more data coming out that showed women who experience unintended pregnancy have 3 times higher risk of experiencing violence against them than women who didn't have unintended pregnancy. And she kind of wanted to look into this further. At that time, the CDC had published a report indicating that 1 in 4 women in the United States experienced violence by a current or former spouse or boyfriend. And so she wanted to look at this interface between violence and unplanned pregnancies and sort of look at what was happening upstream of the unintended pregnancy. Like why is this happening to these women? And so she hypothesized that there's a specific element of male behavior that was abusive and controlling that may in part explain the association of partner violence with unintended pregnancies. She hypothesized that this is done in the following ways. So she described overt pregnancy coercion. She described direct interference with contraceptive use, and then looked at the overall exposure these women had to violence overall in their lives, and seeing if this had something to factor into that. So what she did was that she went to a family planning clinic in California, and she provided a survey for the women who were seeking care there. And she had about a little over 1,200 responses. And she had a series of questions that were both in Spanish and English for women and adolescents ages 16 to 29. So these were young women. She measured unintended pregnancy by one positive response to the question, how many times have you been pregnant in your life when you didn't want to be? And she defined intimate relationships as dating and sexual. She defined lifetime histories of abuse using two scales. One was the conflict tactics scale 2, and the other one was the sexual experiences survey. Now these, especially the conflict tactics scales 2, has been used since the 1970s to study domestic violence and the interaction between partners. So it's been used for a long time. I know there's some criticisms of this. I'm not a social scientist, so I can't really speak to that, but that is the tool that she used. And it's been used in research for decades, especially in this sphere of domestic and now what's called intimate partner violence. And so the questions that are asked are questions like, they're asked of the both partners. So, but you can also ask it one partner separate from the other. So it's questions like, I used a knife or a gun against my partner because they didn't do X, Y, Z, or I used force because I wanted X, Y, Z. And then the respondent, the partner, will say, my partner did that to me. So it's sort of it's a pretty long questionnaire. They had a modified one that they used, which had a little fewer questions. And then the sexual experiences survey measured the incidence and prevalence of sexual aggression and victimization that was perpetrated against females. And these questions are questions like, have you ever had sex when you didn't want to because a man had threatened you or used a degree of physical force against you if you didn't? Or have you ever had sex when you didn't want to, but you felt overwhelmed by the man's continual arguments and pressure? So all these questions were asked of these women. And then to study pregnancy coercion, she asked a series of very specific questions. And these were as follows. Questions like, have you ever had a partner who told you not to use birth control, who said he would leave you if you didn't get pregnant, if he told you he would have a baby with someone else if you didn't get pregnant, if he hurt you physically because you wouldn't get pregnant, or if he tried to force you to get pregnant, and have you hidden birth control from your partner because you were afraid he would get upset with you if he found it? And any positive response to those questions was considered exposure to pregnancy coercion specifically. Birth control sabotage, similarly, she and her team came up with several questions that they asked these women, very specific, like, have you ever been exposed to a partner who took his condom off so you would get pregnant, or put holes in the condom, broke the condom on purpose, prevented you from going into the clinic to get birth control, or made you have sex without a condom so that you would get pregnant? And any positive response to those questions was considered birth control sabotage. So of those respondents, 53% of the women sampled reported a lifetime history of physical or sexual partner violence. And so those questions that I talked about in the beginning, they get into some pretty aggressive acts towards women. And over half of these women were exposed to some kind of violence like that in their lifetime. And these are very young women. 16 was the youngest. 19% of the population that she studied also reported pregnancy coercion. So answers to those specific questions that she had designed answered in the affirmative that yes, they had been exposed to that. And 15% reported birth control sabotage. So overall, the synergistic effect between pregnancy coercion, birth control sabotage, and intimate partner violence, they were all independently shown to increase the odds of unintended pregnancy, but together they more than doubled the odds of an unintended pregnancy. So if the goal was to look at the unintended pregnancy and look kind of at the upstream effects as to why that occurred, this was one of the first studies that actually looked at that. And so what became of the study was it prioritized efforts to reduce unintended pregnancy, which was the outcome that was looked at, by reducing the barriers to contraception that she had noticed looking at analyzing this kind of the upstream effect of not having contraception or being coerced into not using it. And also to provide intervention programs to reduce the harm related to the intimate partner violence that these women were experiencing. So I don't know if anyone has had experience with that. Many times now in the clinics, we have been asking for many years now, screening questions just to make sure that, women are not being exposed to this kind of violence or coercion between their intimate partners. Around the same time, another doctor by the name of Dr. Silverman was researching intimate partner violence as well. But he was specifically looking at the outcome of unintended pregnancy and the result of women who are exposed to abortion. And he was concerned that abused women were more likely to experience abortion based on the fact that women who experienced unintended pregnancies were more likely to experience violence against them. And so he looked at specific actions of men themselves, and he asked them what they were doing to perpetuate this violence. So he went to 3 large community centers, health centers in the Boston area, and he conducted a survey of men who were between the ages of 18 and 35, and he had about 1,300 respondents. And just to get an overall sense of studying their lifetime history of perpetration of physical and sexual intimate partner violence, he asked the same questions that had been asked by Dr. Miller of the women. So the conflict tactics scale 2 questions and the sexual experiences survey. To study the men's involvement in pregnancies that ended in abortion, he just asked them one question: how many pregnancies have you been involved with that resulted in abortion? And they could answer 0, 1 to 2, or 3 or more. And then to study conflict over abortion, he just asked a single question, and it was, have you or your partner ever fought about a pregnancy? And a positive response was, yes, we fought because I wanted her to have an abortion, but she did not. Or yes, we fought because I wanted her to not have an abortion and she wanted one. So of those results, over a third of the men had been involved with pregnancies over their lifetime that had resulted in abortion. And of those 1/3, 48% of them, so close to 50%, reported some perpetration of intimate partner violence. And if you look back at the study that Dr. Miller had done, looking at women's responses to those same questions, was 53% of them experiencing violence. And here on this study, you have 48% of the men saying that they admitted to violent acts against their partners. So they match up pretty well. It's not like one group said, oh, I'm experiencing it, and 90% of them experienced it on the women's side, and only 10% of the men admitted to doing it. It was pretty evenly matched. And 19% of the men reported some disagreement about abortion, with 14% of the respondents indicating that they had sought to prevent an abortion when their partner wanted one. And 7.5% indicated that they sought to compel their partner to have an abortion when she did not want to have one. So the key findings that of Silverman and his team were that abusive men were more likely than their non-abusive male peers to be involved in pregnancies that ended in abortion. And female partners of abusive men may seek abortions because of their fear of having a child with this man that may limit their ability to leave, or fear for abuse of the child themselves from that same man. His data described the significant threat to women's reproductive control related to violence from their male partners. And he actually said in his paper, however, these data in no way indicate that women's access to abortion services should be impeded, but rather reductions in abusive men's coercive control over a woman's reproductive choices may well reduce many women's need for such services. So he put the onus back on the men and said, this is, if these men are being abusive, these women are feeling that they are in unsafe environments, and maybe their only recourse is to seek an abortion, even if it might be against their will because their partner wants them to, or the opposite. She wants to seek an abortion because she wants to prevent abuse of her child or her current children by that same man. So we know that violence against women in this setting is of unintended pregnancy is much higher than in pregnancies that are planned. So again, in summary, reproductive coercion is a hidden form of violence against women, and it includes behaviors that are intended to control or dictate a woman's reproductive autonomy for the express purpose of preventing or promoting pregnancy, based on this original research. I feel like since this first was researched over a decade ago, it hasn't really gained a lot of traction. And we know, however, that our current data on pregnancy-associated mortality and maternal mortality related to violence is increasing. And this is irrespective of the time in the pregnancy that the pregnancy is terminated. So this could be a term pregnancy and the woman gives birth to a term infant, or it could be the pregnancy was terminated early in the pregnancy. She's still at risk for violence within that year of when the pregnancy was terminated. She's also still at risk for violence if the pregnancy was lost due to a miscarriage. So a lot of these data are coming out still that this is still an issue. We haven't really looked at this well enough. And perhaps we kind of need to refocus our efforts in this space. And so some of the data that's come out from reproductive coercion, and I think possibly this is why we're not hearing that much about it, is because there's some issues with defining it, what it is and what it is not. And there are two researchers from the University of Melbourne, Doctors Laura Tarzia and Kelsey Haggerty, and they posit that the reason why reproductive coercion has not garnered more attention is perhaps the lack of clarity around what it is and what it isn't. So there's some inconsistencies in definitions and poor understanding of how it intersects with violence. And so the sort of the robust analysis of this concept is sort of lacking because sometimes it's too inclusive. And so they wrote a position statement and call to action, basically to say a way we can conceptualize reproductive coercion going forward is going to center perpetrator intent and the presence of fear and control in the victim. So what they're saying is that intimate partner violence and sexual violence are the mechanisms by which reproductive coercion is perpetrated. So in other words, it can't exist. Coercion cannot exist without some other form of some violence occurring within the relationship of some kind. And they go on and define what that is. So they specifically state that this violence and control, sexual, physical, or psychological, perpetrators use against women in reproductive coercion is either going to be to promote a pregnancy or prevent a pregnancy. So there's behavior around that control over women, specifically as it relates to their biological function of a pregnancy. So examples that they give of pregnancy promoting that could be abusive are physical violence if a woman refuses to have sex when there's risk of getting pregnant, forced sex to cause a pregnancy, threats to harm a woman or her children if she does not get pregnant or if she tries to prevent a pregnancy. And there's also pregnancy preventing mechanisms that they use to control and abuse women. And they define these as forced sterilization of women, specifically vulnerable women, threats to women to harm a woman or her child and family if she does not have an abortion, the use of physical violence to induce a miscarriage, contraceptive sabotage, emotional blackmail, and threats to force women to have an abortion. So all of these are considered to be pregnancy preventing. And what I want to focus on with the pregnancy preventing aspect of this is how, when they introduce the concept or the statement of forced sterilization as a pregnancy preventing tool that can be used against women coercively, that enters the medical profession and the medical doctor and the physician-patient relationship as one that could potentially be harmful to the woman if there's coercive control exercised on behalf of the medical side. So we already know that this has an egregious history. Forced sterilizations of women against their will, unfortunately, has a very long history in this country. And I think that's why they and around the world, I think that's why they included that in their behaviors, because a partner can't do that to their, an intimate partner can't do that to their female partner. Only the medical community can intervene in that way. And so with that piece in there, with a specific technological tool that can be used to potentially coerce a woman in the definition of a pregnancy preventing intent, then we get the medical profession in on this discussion of intimate partner violence against women and its relationship to reproductive coercion and control. So that's sort of my hypothesis now in terms of looking at this relationship between the medical community and the woman, and that what that relationship is and how that looks in this space of wanting to promote reproductive justice, but also recognizing that there's a risk of coercion. So I really think it's important that we focus on intent, like the researchers in Melbourne discussed with their most recent paper. I think it was about a year ago, they published this, to say reproductive coercion, we need to focus on the intent of the perpetrator. And the intent, if we don't look at intent and only focus on outcome or only focus on access, then we're gonna miss a whole group of vulnerable women that we need to care for, and we need to make sure that they are not being exploited under reproductive coercive control. So where I'm kind of going with this is, for a long time, the doctor-patient relationship under Roe was the one that was sort of codified with their original opinion. The power was given to the doctor in that ruling. So the ruling actually states in the majority opinion that the attending physician, in consultation with his patient, is free to determine without regulation by the state that in his medical judgment, the patient's pregnancy should be terminated. So the word physician appears almost 50 times in that opinion, and the word woman appears maybe 45 times, 44 times. So with that ruling, the push has been, and rightfully so, has been for women to be able to access the medical services in order to achieve the reproductive goals that she has. And from a reproductive justice standpoint, that is completely within the framework of what that is. So access is key. You have to access the system to be able to achieve your reproductive goals in whatever way that is. And in specifically regarding pregnancy termination, it's access to abortion services. At that time, in 1972, the only person that was in that equation, aside from the physician, was the woman herself. And the intent, her intent or the doctor's intent, wasn't really looked at because, that was by design. It was, there shouldn't be a reason. We shouldn't have to know. She shouldn't have to disclose. It was private. But as long as the doctor said it was okay, it's okay. But in 2022, we have a lot more technological means to achieve reproductive goals for many people. And they don't just involve a single woman herself. They involve other people. And I'll kind of get into this as well. So that is why I think if we focus a little bit more on the intent of using the medical profession to achieve access, or to access the medical profession to achieve a reproductive outcome that's desired, we have to look at the intent, because there are situations where we've just looked at where there could be risks of coercion if we don't. And so from the medical community themselves, or for other people that have interests that may not be in the best interests of the woman who is being subjected to this reproductive coercion. So I'm going to kind of go over a couple of examples, and then maybe we can discuss it a little bit in terms of what this means. So as I mentioned earlier, in 1972, we didn't have a lot of technological means to achieve reproductive goals for many people who wanted to achieve a pregnancy or not have a pregnancy. We had just a few surgeries that could be done, and that was about it. Now, however, and again, like I said, it only involved the woman herself. It didn't involve anybody else. But now, however, consider something like surrogacy. So that utilizes in vitro fertilization technology that was developed in the 1970s, late 1970s. The technology has advanced to the point now where a woman who wants to achieve her reproductive goals of having a child, but either is unable physically or for another reason is not able to carry and gestate the pregnancy herself, is able to have another woman gestate the fetus. But yet there's two people accessing the medical system to achieve the reproductive goals of one woman and fulfilling under the tenets of reproductive justice, her reproductive goals, what she wants. But in order for her to access that and achieve what she wants, there is another woman there that has to acquiesce to this. And so looking at the intent behind that is very important, because that woman who is now gestating the pregnancy, even if it's not her embryo, it's still her pregnancy. That could be considered a pregnancy, a coercion, in the sense that it's a pregnancy promoting intervention for her. She may or may not feel comfortable with it, but she may or may not feel like she has a say in whether or not she's okay with it. Now, we think of it, when we focus purely on the outcome, of like the outcome that we want for this woman to actualize her reproductive goals of having a child, we just focus on that and we say, that's the goal, and the technology is the access, and that's what we're going to focus on, access and outcome. But if we ignore the intent, we ignore this whole other person that is involved in this actualization of this other woman's reproductive justice fulfillment, but at the cost of this other woman's potential risk of exposing herself to reproductive coercion. And so that is only being able to be discussed now because we have the technological tools to help people who could otherwise not access their reproductive goal. Now they can, because of in vitro fertilization technology, egg retrieval, all of those things that didn't exist in 1972. Instead of just one single woman, now we have two. And we have the families of now one woman here and the other woman who's carrying the pregnancy. So where the medical profession comes in here is we also have to look at their intent. What is their intent? Is their intent altruistic as well? Who are they selecting who is appropriate to be a woman who's able to carry a pregnancy and then give her baby away? Are they motivated by money? In many countries, they cut this off at the pass. They say, we don't even want this to be an option because we know that the risks of reproductive coercion and abuse for the woman who's carrying the pregnancy are too high. So we're going to make it illegal. But in other jurisdictions, it's not illegal at all. It's fully legal. And we have to reconcile what this is. And someone's rights are going to be impeded upon. So it's almost like your rights end where someone else's begin, because now we have two people in the equation one's trying to actualize their reproductive goals at the expense of possibly exposing the other woman to reproductive coercion. Another example is in the emerging field of uterine transplantation. So again, you have two individuals, one of whom their reproductive goal is to gestate a pregnancy, but they may not be able to do that for whatever reason. And they want to do that. And so under the tenets of reproductive justice, if we focus on the goal, which is to allow that woman to have a pregnancy with a uterus that is not hers, that has to be procured from another woman. But if that's the focus, which it tends to be in these situations, especially in the United States, we focus on being able to give her access to that. So again, here's that access and here's the outcome that we're focusing on. But yet the intent to get to that point means that we have to be able to be okay with taking a uterus from someone else. And in doing so, that can be considered, and it is, a pregnancy preventing procedure. We've just taken something out of another woman so that she can no longer be pregnant, to give it to another woman so that she can. And this is a very new phenomenon. The techniques have been honed, I guess, over the last 2.5 decades. And it's very limited. It's experimental still. But as a society and as the trials have gone, focusing on this access and outcome for this woman who's receiving the transplant and her goals of a pregnancy have eclipsed, again, this concept of access and outcomes have eclipsed the other part of the whole picture, which is another woman is having their uterus removed and undergoing a pregnancy not reduction, but she's not able to get pregnant. She's not able to recognize her reproductive goals. And we've assumed that these donors are doing it for, altruistic reasons. This is experimental. So many times people will say, well, no, they're doing it because they want to give this chance to their sister or their daughter, their cousin. So it's still in that space of working with sort of altruism. But once we normalize that this is something we are going to be okay with as a society, then we have to be prepared for other uses of this technology. So we know, for example, there are some individuals with gender dysphoria who are born without a uterus because they're male and they want to have a transplant. This has been described in the literature in recent years. Some have said that they would like to have a uterine transplant, and doctors are saying that there's no ethical reason why they shouldn't have one. And again, where are we prepared to say, if we're just going to focus on access, we're just going to focus on outcomes, and we're going to say that that's okay and ignore the intent of what's going on with this other woman who has to give up her part of her body for somebody else to achieve their goals. She's undergoing reproductive coercion potentially, while this other individual is allowed to have the right to recognize their reproductive goals under reproductive justice. So that's the dichotomy. That's where there is this, I feel like it's potentially has the risk of being mutually exclusive, especially when you have these technologies that rely on two different people to achieve the goal of one at the expense of the other. And so that's sort of where I wanted to discuss this topic of reproductive freedom, because if we are, as a society, saying that these things are going to be okay and use this technology, we have to be prepared to answer some of these questions. And in in all of the literature that I've looked at regarding all these emerging technologies, especially with surrogacy, there's not a lot of work that's done looking at the woman who's the one who's bearing the burden with her physical body in her reproductive capacity. And I feel like that is an area where we already know, based on the literature, that there's risks of reproductive coercion in any relationship. And if they're already vulnerable women who have experienced that, then who are going to be the women who are going to have to experience some of these other things that are more technologically advanced than what we were able to provide in 1972. So that's where I'd like to end this. And I'd love to hear people's comments or questions and kind of what your thoughts are about this concept about reproductive coercion versus reproductive justice. I think we have like maybe 15 minutes or so, but if anyone has any questions, I'm more than happy to answer. Thank you all for your time.
Thank you. Thank you so much, Dr. Thompson. This has been really a great talk so far, and I'd love to see questions from our participants. We have one so far. Please feel free to drop your questions in the Q&A box. But we have a great one so far in here. So forgive me if I pronounce your name incorrectly, but we have a question from Joselle, who says, I am a nurse who works exclusively with low-income pregnant women. In practical terms, how can a provider safely screen for partner intent, and what do we do with that information as we work in partnership with women? I regularly screen for IPV, but not specifically reproductive coercion. And then she adds, thank you for this great talk.
No. Well, thank you for the question. Yeah, that's a very good question. And I think that, there are some tools that we have, but again, this whole concept and this whole, it's like, oh, screen, and then we're going to try to prevent it. But what can we actually do aside from, reporting? And then sometimes that opens up a whole other issue with women who are already exposed to violence or who may be at risk for being exposed to violence. So I wish I had a good answer for you. I share your concern, because I do the same thing. I'm like, well, I'm screening them and they're saying this and they're saying that they're okay, but then they come back with evidence of physical abuse or more. And what I've done personally in these situations is that I have a very low threshold to just talk to women and just tell them that it's my recommendation that I call a social worker or that I call law enforcement, and they can talk to me if she wants to sort of stay out of it. It's her choice. But I feel like sometimes that has broken down some barriers. So it puts the onus off of her. And because I think a lot of times these women feel like their hands are tied. They don't know where to go. And they don't know if they disclose something or someone's gonna, something worse is gonna happen to them. So I don't know if that answers your question, but I share your concern and frustration, because it's very challenging. And that's why I think in this work, if we can really pinpoint like these questions that Dr. Miller asked were very direct. And so once we have these data, we can be like, look, we know that this is happening. We know that we have to have a plan for these women that within, the legal structure that we can act upon. Otherwise, it's going to be kind of this, where do they go? How do we help them? Yeah.
Thank you so much. All right, we have a question from Amber. She says, thank you for your time and thank you for bringing up surrogacy. It is disturbing to think that procedures like these are so normal. It is even more disturbing to think that clinicians are saying there is no ethical impediment for men seeking uteruses. So sorry, so it's not exactly a question, but did you have anything to add there, Dr. Thompson?
Yeah, it's, it's an area I think we're going to have to, once we have this technology and once it's been developed for women, Now all of a sudden they can use this, and this is how the thought process goes. They're going to expand their market in whatever way they can. And I know that may sound a little bit, that may be a little bit unfair, but I really do think that that's part of it. I also think that they sort of think that they are doing something that is so altruistic and groundbreaking that they're almost above any kind of scrutiny. These are my opinions. But it is, I mean, if you read these papers, there is never a mention of, where are we going to get the uterus from? And some have gone to the point of saying, well, if there are females who identify as masculine and they want to have gender confirmation surgery, well, we'll just take it from them. So you're gonna take away that individual's ability to achieve a pregnancy at some point in her life. It may not be now, but then so even having that discussion, so you're already talking about a vulnerable group, and then they're talking about doing that kind of procedure and taking that agency away from that person. Yeah, I follow this space very closely. And so, yeah, if I have any more papers that I find or scientific presentations that I know of, I'll keep you updated through Wolf.
Speaking of that, actually, we had just a comment in the Q&A box about dropping links to studies and things like that in the description when we put this up on YouTube. So I just wanted to mention that Dr. Thompson has some of those things already prepared, and so we'll definitely put that together to have that accessible for everyone. So. Awesome. So we have another question in the Q&A. So Amber asks, how do we stop this, especially in states where women have limited reproductive rights as it is?
Yeah. Like stopping the surgery part of it, the surrogacy part. Or just kind of
I think probably, yeah. I think that's probably what she's in reference to.
Yeah. What's really interesting, and this has been sort of hard for me because it's hard for all of us, but when I read the original, first I read the original opinion by SCOTUS back in 1972, and how they talk about the right. I kind of read a little snippet of it. It's a really long opinion. I think it's over 100 pages, if I'm not mistaken. The wording in that document does open up this physician. Really, a lot of power lies in the physician, and so under that, I think that's how a lot of these initial sort of procedures and surgeries and ways of for lack of a better word, I'm going to say manipulation of a female body, kind of got in the door because doctors were allowed to. I mean, it says right there, no one should question them. Doctors are supposed to police ourselves. It's a profession. And so when you have a mindset that's only focused on these outcomes of like, well, we're going to help this person achieve what they want to achieve, and that's her right to have that, and she needs to be able to access that. If you're only looking in that space, it's easy to see why doctors are going to be able to take it and take whatever they can in the process of being able to generate whatever that means. And the ruling with Dobbs now specifically says that is not, I wish I had, I'm going to see if I can find it here, because it's a really interesting quote. And I apologize. Just a second here. I'm sorry if I can't find it. Okay, so I'll read what the current ruling says in Dobbs about like rights to certain aspects of reproductive autonomy. So attempts to justify abortion through appeals to a broader right to autonomy and to defend one's concept of existence prove too much. So what that means is that the concept of existence, which enables, a male body to seek a uterus as a transplant, as an affirmation surgical procedure for how they want to identify, under the old Roe, that was actually not disallowed, because doctors were given the green light to say that could be okay. And this ruling specifically takes that away. What it also takes away is the ability of, under a federal statute, not a statute, I'm sorry, opinion, is the same ability of a woman to make a choice about what she wants to do with her pregnancy. And so we're sort of stuck between in a catch-22 right now. And I think that probably the way that's going to be reconciled out of this is to have very clear definitions of what is going to constitute. We're just have to be specific in our language, like for accessing abortion versus surgeries in this sphere, because this is not 1972. We are not prepared for any of this really right now, in terms of what technological advances there are and what 50 years ago they were, in terms of trying to navigate now all of these players in this same space. So yeah, it's a really good question. And on the one side, it the current ruling does kind of put a little bit of a halt to the physician power here, in terms of doing these other surgeries and exploiting and coercing women. But it also at the expense of losing what we had under Roe. So we're going to have to work that out in a way that is probably just through a lot of communication and very clear definitions of what is what. Does that answer your question? I know that that's probably a long-winded answer, so.
I'll see if she mentions anything in the chat, okay, or Q&A. Thank you so much for that. And we have another question from Autumn. She says, "Thank you for your clarity. I learned so much." And she's wondering, how does this intersect with sex trafficking? And would this fall under organ trafficking? And if not, why not?
So that's a really good question again. And I think that, this other part of the ruling that I have in front of me with, at least in the United States, with the Dobbs ruling, it says that, let's see, attempts to justify abortion through appeals to broader light of autonomy. Okay. Those criteria at a higher level of generality could license fundamental rights to include, and Alito said, illicit drug use, prostitution, and the like was the latter part of it. But if you take away abortion in that sentence and you put in its place things like uterine transplantation, surrogacy, sex trafficking, where you have a right to have all of these things under the old interpretation, I think that this ruling could potentially help curtail some of those practices, because the old ruling said that or I'll just focus on the new one because the old one is gone. So the new one says that they do not have that right. And that, there might be an easier time of being able to argue that since they don't have that right, that's going to be more able to be maybe prosecuted, I guess. I'm not a lawyer or a legal expert, but if people are doing things that are illegal or abusive or coercive and in that area, the physicians don't have that power anymore. So for them to say, well, it was my medical opinion that this should have been done, may not fly anymore. It's very hard now. Mm-hmm.
Thank you. And looks like we have time for maybe a couple more questions. So if you have anything else you'd like to put in the Q&A box, please put that in now. But in the meantime, I had a question,
Yeah.
Dr. Thompson. I
Yeah.
just love to know, with these, how do you work with any other doctors who, have similar beliefs as you, or are you able to, with your beliefs about surrogacy or being gender critical, is that something that you're, able to express in your field? And have you seen, any other doctors that you work with, like, have similar opinions, or is it still, not very much yet?
So so to, yes, there are other doctors who do share a lot of these concerns. Actually, there are more that share the concerns than not. I don't know if maybe that's reassuring, but there's a lot more that have these concerns than, um, and as doctors, even though we're a profession, but we really work alone in most of our interact. It's our patient and us. That's it. We work with our nurses. We have doctors who are colleagues, but we don't necessarily have like a collective practice or communication, or so when I say that they're concerned, it's based on some side conversations I've had, or something about a patient that maybe I've taken care of and somebody else is taking care of, and we have similar concerns about what happened in a certain situation. And I can say that there are many doctors who are concerned about this, and there are more than you think. So I think that really the ones, though, really what we have to do is work within our medical societies, our medical licensing boards in each of our states to kind of get clarity on what is going to be acceptable to practice in the state. And unfortunately, there's a lot of money behind a lot of these surgical procedures. People want to make a name for themselves. They want, there's a lot of ego involved. There's a lot of money involved. There's a lot of perceived prestige involved in some of these procedures and some of these practices. And so that's the unfortunate reality of where we are at this point. And looking more into the history of medicine and medical practice, I sadly, I'm not surprised that we are where we are right now here. I mean, we barely got over the opioid scandal. We've had lobotomy scandals. We've had Tuskegee. You name it. We've had so many. So it's definitely hard work, though, to sort of make inroads into those decision-making bodies where we can kind of have these conversations at a level that's going to make some of this not be like the Wild West. In this country, that's where we are at this point. So I'm hopeful.
Thank you. No, that is really reassuring to hear that. And I hope that more and more doctors really get the courage to speak out like you are. I think this is this is really great to have you here tonight, and
Thank you
learn
all
from
for
you.
having me.
And it seems like, we have another person in the Q&A just thanking you for this talk, and that it was very informative. So I think we can go ahead and wrap it there. I don't see any more questions in the box. So, oh wait, we have one. Okay, we have one that just snuck in, if you're willing to
Oh yeah, sure.
to stick around.
Yeah.
Okay. So we have another question from Amber. She's wondering, how can we address these issues if women are being sought to be redefined to include males? How do we properly address these issues if men can claim to be women and be granted space or opportunities that are appropriate solely for the female sex? For example, if medical professionals may accept that a man can identify as a woman, then on what basis can the professional deny the man's want for access to women's health care and to procedures like these? Great question, Amber. Thank you.
That's a very good question. And all of this is a huge concern. And this is why, there are some of us who are kind of speaking to this, because I know that there are several people who have, written to professional societies who are, actively promoting this. And I do want to say professional societies in the medical sphere many times do not reflect the attitudes of their members. Does that make sense? So I'll just, the American Academy of Pediatrics is a prime example right now. It's going through an immense amount of scrutiny because of what it's promoting for children with very poor evidence base. And the majority of the members of the AAP they don't agree with these positions that are being taken. And similarly for many other specialties, the professional societies have statements out that many of their members are having a hard time with and disagree with. And there's ways to kind of address that through the societies. And sometimes they're very willing to discuss that, and sometimes they shut you down. And so it's really just on the medical side of things, just sort of constantly knocking on doors, constantly saying things like pushing back, like, no, this is not what we're trained to do. We can't be doing this. I treat the female body, the female reproductive system. I am not trained to, do screening exams for men, irrespective of what genitalia they may have or may not have. If they've had it removed. I mean, if there's enough of us that are willing to ask questions and to say, wait a minute, this is not good care for patients at all. We can't ignore these things. We can't pretend. Then, they have to listen because they're, they know, but it's just a willingness to sort of push back and reclaim that area. And I have to say, it's been a challenge. Sometimes there's been receptivity, sometimes there hasn't been. So I have to be accurate. So yeah, otherwise it's not good care at all.
Are you open to one more question, Dr. Thompson? We have
Sure.
one more in the chat. Okay.
No,
All right. And this will be our last one for the evening. Thank you so much, everyone, for attending. So we have a question from Autumn saying, is it possible to create a medical coalition against the loss of Roe v. Wade and surrogacy? Or what is the solution to this woman erasing culture?
Yeah, I think that if we did have, I think what Wolf is doing is a huge part of where we can go with this. I think that as more and more people are kind of learning and waking up to sort of what is happening to women around the world and in the United States, but really this is a global effort to sort of redefine, rename, use our functional capacity, but that's, at the expense of everything else. And that's where it will go if it's just let to take its natural course. And I guess throughout time, that's always been the case. I think it's just going to take a concerted effort, just as having as many conversations as you can, connecting with as many people as you can. I've been so fortunate to be to learn about Wolf and kind of their work, and that's one example, but there's many more. And I think just women talking to each other and kind of getting the word out, like, wait a minute, this isn't okay, and I'm not okay with this, and my mom's not okay with it, and my grandma doesn't feel good about that either. And just sort of, and a lot of times it's hard because there are people who I know and respect and really care about, and I know that they completely disagree with me on many things, but just being open to having these conversations. And I think I've been reassured in just coming in to speak with people, and I've been reassured at when I thought it was going to be really not taken well. It really wasn't, and people were like, okay, they're a little bit more open to hearing some of these things. So, and I think as time, it's almost like a little drip of water through a rock, and eventually this massive boulder is going to crack. So we'll just be the little drops of water.
Thank you so much. I feel like that's a great note to end on, that we do, have the power to change this, and one conversation at a time can be, part of that change. So,
Yeah.
Well, thank you so much, Dr. Thompson,
Thank you
for
all.
your wonderful talk.